My name's Wayne Brisbane. I'm going to be talking about the prostate, and then it should segue very nicely into what Dr. Young is going to talk about afterwards. So we're going to talk about the prostate, the normal, BPH, and then cancer. And I already saw a couple of questions regarding this, so we'll go through this and let me know how we do as far as answering these questions. So let's start with the normal, and then we'll talk about BPH, and finally we'll talk a little bit about cancer. So I'm going to draw just the kind of rough sketch of the anatomy, because I think this is very important to inform everything else that we do. Watch the time. So Marcia, if I'm getting a little bit long, let me make sure that I stop myself. But this is the pubic bone, okay? This is the abdominal wall going up towards the neck. So this is opening you kind of like a book in we call it the sagittal plane. This is the phallus, scrotum, perineum, rectum, gluteal muscles, and back. Okay, so the prostate, this is your belt buckle, sits right there. Your prostate's going to sit right behind that pubic bone, and then the bladder sits on top of the prostate. There's a tube that goes through this and drains the prostate. It's called the urethra. The rectum goes in close like that, and then goes and attaches to the rest of the intestines, and then your spine is shaped something like that. So this is a rough approximation of where your prostate is, and you can see that it's in the middle of the urinary system, the GI system, and the reproductive system, like Dr. Campbell was talking about. But this is what a really nice representation looks like, drawn by Dr. Netter, who's very famous for doing these. And we're going to use this outline, but there's the prostate. You can see again, this is the bladder, this is the reproductive system. So the sperm are getting produced down here and then going into the prostate, and then it's right by the GI system as well. So kind of at the crossroads of a lot of things. So there's a lot that can go wrong with this little organ. So what does it do normally? What's its importance? Why does it exist? Well, it is only for reproduction. That is what Mother Nature put it there for. So its function is to support the sperm, and the glands that are doing most of the work kind of follow this weird Nike shape orientation. So that's where they sit, and they secrete proteins, minerals, and multiple different factors that are their job is just to support the sperm. One of these is PSA, and many people have heard of this protein. It's called prostate specific antigen. Only the prostate produces it. That's why it's called specific. But it can go up for multiple different reasons, which we'll chat about. But the job of this protein is to liquefy the sperm so that it can be used for insemination. So that is what the prostate is supposed to do. Let's talk a little bit about what can go wrong with the prostate. So many people have heard of BPH, or my prostate is enlarged. This stands for benign prostatic hyperplasia, benign being not cancerous, but the prostate can grow. So here's our representation of the prostate in a normal-ish size state. And it's important to note that the prostate has a couple of phases of growth through life. So it starts off really, really small, about 3 to 6 cc's, and to note that that's about 5 cc's is about the size of a nickel. So when you're born, this is a very, very small thing. And then when you're in puberty, there's this exponential growth into this 20 to 30 cc range, where that will hold you along this plateau until about 40. And then, for reasons that we don't perfectly understand, you have this, most men, I will tell you, have this kind of continued growth, not quite exponential, but progressive and continued growth. And that just happens until we die. So this can cause all kinds of problems. So you have this peripheral gland that we talk about. This is where the glandular peripheral zone, this is where the glandular tissue lives. And the glandular tissue is going to produce most of the cancer. There's also something called the transition zone, and this is what causes all the BPH and which results in your urinary symptoms. So when this thing grows, it tends to grow in on the urethra. So it pinches the urethra, it narrows it so that the urine can't get out very well. And then some men will develop this knob right here called a median lobe. And if you look at it from the urine standpoint, this almost acts as like a ball valve that can close as you're trying to have the water go out or the urine go out. So both of those things, the narrowing and that ball valve effect, can make it very difficult to urinate. Now, the bladder is a muscle. It's basically a muscle ball, and it is going to respond to this difficulty with getting urine out by increasing in strength, okay? Just like Hulk Hogan, if you think of this is like the Hulk Hogan bladder or the Rock bladder. It's just a very, very big, fibrous, muscular structure. And as a result, it does not relax very well. You can picture for yourself the Rock or Hulk Hogan trying to do yoga. It just doesn't work very well. And so what this leads to in symptoms are a couple very important things that many people are very familiar with. Urgency. This doesn't relax very well. That means a little bit of urine makes the bladder want to empty. Frequency. You can't store as much, so you got to empty multiple times. Outlet problems. This is weak stream because you can't generate as much force getting out this way, and slow starting the stream. And then there's some things that are combinations, so incomplete emptying. You can see that if the urine is really full, then the bladder can compress to some extent and get it maybe down to this part, but it's just hard for this bladder to fold in on itself and get everything out efficiently. So there's a little bit of residual. And so you're incomplete emptying. And then you, instead of working with this entire volume, you're emptying with this volume. And so you have to frequently empty. This can be really disruptive during the night. Nocturia is something that many men suffer from. And it's really debilitating because good sleep is something that's hard to come by. So what are the things that we do about this? How do we intervene? There's about 3 different levels. One is modifiable factors. These are things that you can do without a doctor's appointment. So removing caffeine. The other one is alcohol. So these are stimulants inside the bladder. It's like having a porcupine rolling around in here. It's going to cause you to need to urinate much more frequently than if just normal urine was there. The other thing is watching your fluid intake. Now, we live in the Southeast. It's very important to stay well hydrated, lots of kidney stones here. However, if you're having a lot of trouble with nocturia, meaning getting up to urinate, and you're also drinking right before going to bed, those kinds of things are important because whatever goes into your kidneys, this is my kidney up here, has to come into the bladder eventually. And so you can do a lot of help for yourself by limiting fluids right before bed. If you want to do this, you can look up a void log. It's VOID-LOG. There's some really easy paper and pencil ways. There's some apps that you can get there, and you can track what goes in and what comes out, and you can see when that happens. And that will really prepare you to see, hey, are there things that I can modify that are simple without a doctor that are going to help me get a better night's sleep? And so I recommend doing those kinds of things before you see your physician. It also gives you better data to really nail down what's the problems. There's also some medications, specific ones that are often offenders are like diuretics, often called water pills. And sometimes the timing of these are important. If you take them right before bed, they can cause problems. But also you have to really consult with your physicians about, especially your cardiac physicians, about when these need to be taken. Sometimes there's no way around it. Something I didn't put on here, but I probably should, is called sleep hygiene. You know, there's just some other parts about sleeping that are important. And I'm not a sleep specialist, but dealing with nocturia has made me learn a little bit about sleep specialists. If you snore a lot, CPAPs are important, making sure that your bedroom is optimized for sleep. But it's beyond the scope of this conversation, but your primary care doctor can talk to you about it or get you over to see a sleep specialist. The next thing that a lot of urologists, but a lot of primary cares are involved in is giving a medication. This is the next line. These are the things that you need a doctor to intervene on. There's a couple different types of medications. This one, alpha blockers, these green areas that I outlined through here, now turning red, are these smooth muscles that contract at the bladder neck. They're part of the prostate, part of the bladder neck. These medications, alpha blockers, block that medication, so it allows them to open the channel and allow urine to exit more efficiently. This is called Flomax. I think this is Uroxetrol and Rapaflo. They've got simple names, but you can see they all have this similar OSIN, which means they're alpha blockers. The Flomax is very, very common medication. A lot of men take it, and it's very effective too. PDE5 inhibitors, something that Dr. Campbell mentioned, is tadalafil. This is Cialis. It also seems to relax the smooth muscle right around here. And so that can be another medication that's effective for kind of opening this channel, especially for men who have concomitant erectile dysfunction. You kind of get a twofer for that one. Another way another class of medication that takes a second to explain. This central zone. Its food source is testosterone, but a really kind of strong version of testosterone is called dihydrotestosterone. It's about 10 times stronger than testosterone. And you need this enzyme 5-alpha reductase in order to convert the testosterone to dihydrotestosterone. So we think that this dihydrotestosterone is somewhat important in stimulating the transition zone to really grow big. And so by blocking that, there's medications that are called 5-alpha reductase inhibitors. The medications are called finasteride Proscar and dutasteride, which I don't remember the trade name right off the top of my head, but they basically block 5-alpha reductase, and they'll shrink this kind of area in the prostate. As you might intuit, really small prostates are going to favor this. Really big prostates are going to favor this. They're synergistic, so they work by different mechanisms of action. Sometimes you need both. And I've had men, rarely, but some men are on all three. So those are the medications, and in the general class, that's what they're doing for people to try and help get this urine out. There are also a subset of medications that are affecting just the bladder, and Dr. Young may talk about them, but there's a whole nother set of medications that just affect the bladder if most of the symptoms you're facing are storage symptoms, the urgency, frequency, but the urinary flow is fine. So that's another class of medication that can just affect the bladder. Those come in two main types, but I'm focusing on the prostate, so I'm not going to go in. So if let's say the medications we've gone through, I'm going all the way back. We've done the modifiable factors, that didn't work. We've done the medications, that didn't work. Now is the time to talk to a urologist about some surgical options. Now, these are all the surgical options, the alphabet soup from the AUA guidelines. I think it's a little funny, but I just put them all down there to show you that there's a lot of ways to treat the prostate. You can shoot it with a laser. You can pin it against something. You can take a robot and excise it out. There's just a lot of different ways to get the same thing done. And the same thing is what we're trying to do is open up this channel so that the urine empties much more efficiently. We think that this will also eventually then modify the bladder so it relaxes with time. It's able to become less muscular and fibrotic. It stores better, but that's the idea. So I'm going to keep on moving, but that is BPH in a whirlwind. So we've talked about what the prostate does. It is there for reproduction. We've talked about what can go wrong. It can get big, and as a result, it can cause some bladder problems. And those have, about a 3-stepwise things that urologists are thinking about when we're treating people with BPH. And now we're going to talk about prostate cancer. Because prostate cancer is very prevalent. 1 in 9 men are going to get prostate cancer. It's about a 12.5% lifetime risk. And so it's something that if you don't get it, one of your friends will. And it's important to know a little bit about prostate cancer just to be a good citizen, I think. So this is back to our outline of the prostate. And I'm adding in 2 more features that I didn't highlight previously. These nerves that Dr. Campbell talked about are these wispy sympathetic nerves that kind of come down and they plug into the corpora right here. That's what he was showing you previously. This is the corpora cavernosa. These are like the telephone lines from your brain to the corpora. They have nothing to do with libido. They have nothing to do with the pleasure of sexual intercourse, but they are completely the telephone lines to get the hydraulics running. So they send you from a flaccid state to an erect state. They are very, very close to the prostate, which will become very important in a second. The other thing that Dr. Young is going to talk to you a lot about is there's this muscle complex called the external sphincter, and it surrounds the urethra, hugs the prostate, and its job is to pinch off the urethra in order to close this urinary stream so urine doesn't come out. And those 2 things are affected by treatment, so that's why they're important to keep in mind. So as we talked about PSA, most men are getting PSA checks in order to screen for prostate cancer. We're going to talk a little bit more about this, but the simple way to think about it is there's something growing in the prostate. It kind of squeezes the PSA into the blood. And so that's why with prostate cancer, PSA starts to go up. There's other things that can make your PSA go up. Size of prostate is a big one, but riding a bike, if you're sitting right here, obviously this is a bike seat. There's some debate about this, obviously, but that's going to put a little bit of pressure on sexual intercourse. So if you ejaculate, that's going to dump a bunch of PSA into the blood. The important thing that I want you to take away is that PSA is not cancer specific. There's lots of things that can make your PSA go up. But cancer is on that list, and it's one of the things we worry about. That's why PSA is a screening test. So let's say if your PSA goes up, the next step is often a biopsy. So this is my rendition of a biopsy where it's a transrectal ultrasound and then this needle, which is directed into this. This gets into some of the research that we're doing here at the University of Florida. This is the conventional ultrasound. You can see it's very grainy. This is the micro ultrasound that we're using here. The resolution is about 300% better. You can see that there's actually an outline of a tumor right here, which is completely invisible on conventional ultrasound. Extreme implications for both diagnosis and treatment. For diagnosis, we're able to put our needles right where we need to instead of just SIPs kind of blindly harpooning or putting needles into the prostate systematically. So we're able to direct this a little bit better. We also use MRI on top of this. So we're really using two different imaging modalities fused into one to really put the needles where they need to be and not everywhere else. So that's something that we're working on to really help us guide our diagnosis. So let's say we get this biopsy and they look something like this, look like a little pencil lead down here. And I put the tumor right here. So the pathologist, they're going to look at this little piece of tissue that comes out of the biopsy gun, and a little piece of that transected the tumor. And so they say, well, this is about 2 centimeters long. This is about, we'll call this 5 millimeters. And what are they looking at inside that 5 millimeter band? Well, this is what a normal prostate gland looks like. It's a bunch of cells that are these little blocks right here that are surrounding a common working lumen. And then there's this very important basal lamina that goes around, and it's kind of like it's a foundation for these cells. It keeps them all oriented and working in the correct direction. So it will take blood and nutrients and it will process those and dump them into this common working channel. And we talked about PSA as one of those nutrients. Now, it's important because Dr. Campbell was talking about how does testosterone play a role in this? Well, testosterone is like the food source for all prostate cells, normal, cancerous, and otherwise. So as long as you're, not super therapeutic on your testosterone, you're physiologic, it's fine to take testosterone. But it's the gas pedal for cancer, no doubt. And so if you do have cancer, it can be very dangerous to take testosterone. There's also some tumor suppressor genes, but I always think about it this way. Either the gas pedal is too, floored too much, or one of the brake pedals is malfunctioning. And what that leads to is more cellular division, more growth, less function. And so this common working channel is getting smaller. It's not working as well. If this progresses and the basal lamina falls off, so it's outstripped the basal lamina, that's where you cross the line into cancer. Okay, so when these look like little glands, they kind of resemble what they're supposed to be, but they're not interacting with the basal lamina anymore. They're not doing their job. If these things start fusing together, that's even more aggressive. And if they really just kind of forget how to look like glands at all, they become these little just single cells packed together for space. They don't really care about working at all. That's even worse. And you can see this is more and more dysfunctional over time. You can also see how PSA, which is supposed to be taking blood and nutrients going in here into this common working channel and out to support the sperm, no longer can do that. These little working channels are so small and these cells are so kind of not working well that the PSA just gets leaked right into the blood. And that's what causes your PSA levels to go up in cancer. So the pathologist looks at this little section and they say, okay, well, this stuff is abnormal. We need to grade it, all right? And this is where, if you've heard of this Gleason grade, this is how it gets its name. It's a pathologist named Gleason, and he looked at this tumor and said, well, you have to be at least on this side to get cancer. And so we're just gonna see whatever I see the most of goes right here, and whatever I see the second most of goes right here. So those numbers. So, you might see 3 plus 4. Well, that would be majority of this with some of this. But if you saw 4 plus 3, that would be majority of this with some of this. And you can kind of combo those in your head. This is important because every prostate cancer, we need to put it in a risk bucket. Okay, not all cancer is the same. It's very heterogeneous disease. These all need to be in a risk bucket. And so these are the buckets. There's low bucket, intermediate risk, and high risk. And a big driver of this is the Gleason score. It's very important to kind of see how aggressive is this tumor going to act, its potential for being aggressive. It doesn't tell us where we are, how big the tumor, it just tells us how aggressive its nature is. So 3+3 is low, 3+4 and 4+3 is intermediate, and high risk is greater than 4+4. And so 4+5, 5+4, all that stuff. There's also a very low risk disease and a very high risk disease. I think that's kind of nothing you need to worry about. I think 3 buckets is just fine. It actually captures things very nicely. Another thing is PSA. So PSA, we talked about it. It's not cancer specific, but it tells us how bad is something. It's kind of like a canary in the coal mine. So PSA is less than 10. You can say we caught this early, so it's in the lower risk side. 10 to 20 intermediate, greater than 20 is going to be high risk. The other thing is stage, and we do this with our finger. You saw, the prostate portion that produces cancer is right next to the rectum, so you get your urologist can feel the prostate. That's why we do a PSA plus digital rectal exam. To kind of get this stage. Is the tumor completely confined within the prostate? We don't see it, we don't feel it. Is it kind of bumping up against the prostate wall so we can feel it if we push? Or is it kind of climbing out of the prostate? And that's, we call this T1 for more or less, T2 and T3. So these are our risk buckets, all right? And the key for prostate cancer treatment is this balance. We're balancing cancer control versus length and quality of life. All right, I'm putting these down there. These are very important studies within prostate cancer. Beyond the scope of this talk, and urologists debate this actively, the SPCG4 and the Pivot, the most recent data was just published like a couple of years ago in New England Journal of Medicine. So this is pretty new stuff, but these trials have been going for 30 years. So SPCG4 and Pivot basically flipped a coin. Some people got surgery, some people got nothing. Protect, they flipped a coin. You got watching, surgery, or radiation. It's a more, I'd say, modern cohort. These didn't have as much PSA screening. This had PSA screening. But if you take these as a whole, my takeaway that I'd like you to say is prostate cancer treatment is important, but you have to be careful not to overtreat. That's the takeaway. And I'm gonna case that in, you just have to make sure that everyone is appropriately being treated within their risk bucket. So once you find a risk bucket for you or a loved one, a friend, there's different treatments that we do for each bucket. So we're going to treat the cancer how it wants to be treated. How risky is it? So with low risk disease, active surveillance is usually just fine. The active part means we're not letting it go, but we are surveying it. And this is a very safe method. These cancers don't just jump and spread to the rest of the body. The worst thing that they can do is kind of transform into something else. Occasionally we just re-diagnose them. We have a little 3+4 that was hiding, but for the most part, it's, well-diagnosed man, low risk active surveillance is a very, very safe option. There's some caveats to that that are very important that you have to discuss with your urologist, but that is a very reasonable way to go. For intermediate risk, this is something where this is a realer deal cancer. I'm going to come back to that. High risk stuff is very aggressive. We often have difficulty catching that before it's spread other places. And these men sometimes need combination therapy, meaning surgery, oftentimes followed by radiation. Some men get away with surgery, but they might need radiation afterwards as we call it adjuvant, just to kind of make sure that all the cancer cells have been killed adequately. If you get radiation, you're going to need a couple of years of androgen deprivation therapy, which is a medication that takes the testosterone out of your body. It synergizes the radiation, makes it work better. And for very high risk disease, sometimes they'll do radiation plus chemotherapy or clinical trials. But there's also this big box in the middle, which is this intermediate. And it's kind of this continuum between low risk and intermediate and high risk, where as you're kind of marching along 3+4, as this 4% goes up, you might want to go for surgery or radiation. But definitely down here, there's the option to do focal therapy, where we're just kind of ablating just the tumor and sparing these critical structures. So focal therapy is a new kid on the block. It does not have the same length of follow-up. You saw those studies, 30-year follow-up. It has about 5 to 7-year follow-up. So we have to be very careful with focal therapy, but it is a good option for some men. And it's one of the things that we like kind of doing carefully on trial here at the University of Florida. So I'm going to talk about a couple of things. I'm not a radiation oncologist, so I will spare you a lot of details in that. But in general, if you're getting radiation, they will either cross the beams at multiple places. So that's one option. Let's see if these will, oh, no, I can't do that. The protons are going to come in and then degrade right here. Or they'll do brachytherapy, where they put seeds or catheters in here and the radiation comes from the outside. As a result, you're going to get this kind of halo. Oh, I can delete that, nice. You're going to get this halo of treatment that definitely kills the prostate, but it can also kill some other things. It can cause like a little sunburn in the bladder. It definitely touches those nerves. Occasionally can cause the rectum to get like a sunburn. And these are the things you would expect. You know, they don't last forever, but you're going to have some more urgency, frequency. If you have some bowel disease already, like ulcerative colitis or something like that, you might want to avoid radiation. And it's not going to do you any favors for your erections, because those nerves are going to get some treatment, plus the arteries that supply the pelvis. Again, not going to talk a lot about radiation because there's a lot more justice that can be done to it. But I'll tell you one thing: equal cure to surgery. Very, very good option. It has a side effect profile that is related but distinctive from surgery and focal therapy. And if you're interested if you have prostate cancer or a loved one has prostate cancer, you should definitely talk to a surgeon and a radiation oncologist. There's usually time to do that. This gets a little bit into my research, which I think obviously I'm very interested in, which is using imaging to really understand and guide what we do. So that's both for a diagnosis, which we talked about, but also for treatment. So we really kind of localize where the tumor is and then allow it to tell us how it wants to be treated. So for this gentleman, he had micro ultrasound, a PSMA PET CT scan, and a multiparametric MRI. I call this the platinum package of imaging. Each one of these imagings has a different physical mechanism of action. So we're getting different characteristics about the tumor from each one of these, and I love them all. And but I do use a composite treatment model. So this model has been created as a composite from all of these imaging sequences. So you can see for this gentleman, his tumor is right against this nerve. And so for him, we decided to do a nerve sparing. This is looking at the nose. So this was nerve sparing on the right and not on the left. Okay. So this is how we do surgery and focal therapy, where we're trying to really let the tumor tell us how it needs to be treated. We're trying to use a lot of imaging and planning biopsies in order to do that really well. So for surgery, again, I will just take a couple of minutes for surgery, but basically the surgery, we're removing the prostate. And so that has two side effects, two big ones. One, we have to peel these nerves off of the prostate, right? The second thing is that you can see this prostate's almost acting like a cork inside the bladder. So depending on where the prostate cancer is, we might have to cut into this muscle right here that's responsible for keeping the bladder, the urine inside the bladder. Occasionally there's some techniques like Retzius sparing technique, some hood techniques where we get really close to the prostate. But again, that's not necessarily for everyone. If you have a tumor that's kind of bulging the capsule, we're going to need to be a little farther away from the prostate in order to do a good job with the cancer control. And that's why I have my colleagues like Dr. Campbell and Dr. Young, who can really make sure that your quality of life is excellent even after good oncologic surgery. I'm going to go, oops, one far. So I think this is pretty intuitive, but for, oh shoot, I did something silly. I'm sorry. For focal therapy, I was trying to get my red pen back, and I'll just go back to my highlighter. For focal therapy, what we do is we basically stick a needle in through the perineum. It's not that big, don't worry about it, but we just ablate the tumor. And what we're able to do there is try and spare these nerves and spare this external sphincter so that you don't get the same number of side effects. And that's the benefit of focal therapy. The detractions are we have to continue monitoring because these tumors can come back in other areas. And it's something that really needs to be personalized to everyone with a lot of imaging guidance. So that's where I'm going to stop. thank you guys for being on, and hopefully we can answer some questions a little later.